And it's a pleasure to be able to have a conversation about diabetes medications today. So thanks very much for joining the Cardiac College Online. This is me, and it's a pleasure to be with you. A reminder that this is one of the educational sessions that we are very fond of running, and the purpose for these sessions is really around education specifically. We recognize that there may be some particular questions that may be on your mind, and we'll do our best to address those questions. But if it is really quite of a personal nature, we might direct you to check things out with your own physician, nurse practitioner, or healthcare provider. If you do have questions that come up as the session goes on, if you'll input them into the Q&A box of the Zoom platform, that'll be great. That way we can keep track of them and address them in order at the end of the session. The kind of the framework for thinking about medicines related to diabetes looks like this. The Canadian Diabetes Guidelines will be one of the reference sources for this section or this session. And the guidelines recommend that we can think about interventions that can help those of us living with diabetes through this fashion in a systematic order. So we think about the A, B, C, D, E, S. So the ABCDs of sorts. And A reminds us that A1C, or establishing really good sugar control, will be the first thing on our list. And then other therapies that might be part of the cocktail or armamentarium from a medical sense include therapies that we've addressed in other sessions, including approaches to blood pressure control, cholesterol control, and other medicines to protect the heart, such as ACE inhibitors or statins or aspirin. We're going to touch upon some other medicines that are specific to diabetes management through the course of the next 30 minutes or so. We're also reminded that we should not ignore the E's, even though that they're the E in this kind of listing alphabetically, that exercise and healthy eating are critically important to all of the domains above. And we should also not forget that smoking cessation is incredibly important for people who are still smoking. But for the next little bit, we're going to talk about the medicines that will help us with sugar control, and in particular, those that have another role in not only sugar protection, but also heart protection. Why might we want to focus on sugar control? Well, there's lots of data, including studies like this one, that looks at the experiences of people living with diabetes over a long period of time. And a number of studies will relate sugar control shown along the x-axis here, this lower part here. And if we categorize people to those that have very normal levels of sugar around the 5% mark, to those with slightly impaired levels of sugar around the 6% mark, to those with established diabetes who have an A1C value of over 7%, you can see that if we look at the risk of developing heart disease along the y-axis, that this risk goes up sharply, dependent on the levels of sugar control. For people living with diabetes, if you don't know what your hemoglobin A1C value is, well, that might be one of the takeaways for today. Typically, we'll measure this every 3 or 6 months for persons living with diabetes as an index of average sugar over that period of time. And clearly, having a lower value for the A1C is more desirable than having a higher level. And that high levels of sugar on average will increase the risk of developing heart disease by 4 times or even more. So having attention to the sugar is really important. Healthy eating, exercising, and medication will all help in this way. If you're looking for more reading materials or a reference source for the diabetes medicine, we'll certainly direct you to the materials that are available at our own Health E University website. Some of you will have logged into the Cardiac College section. The companion to that is the Diabetes College section, and you'll find a guide or compendium of healthy resources. And chapter 7 of the diabetes guidebook is all about diabetes medications. What do these medicines do? What are they? What's good or bad? And who can help you with more information about your diabetes medicine? So that's a kind of a longer, more fulsome review after this section that we might invite you to. And we'll also touch upon other reference sources. So if you're looking for something else on on websites, then you might have a look at the Diabetes Canada website. There are sections for professionals, and there are sections for persons with lived experience. And one of the things that I can pull out from there is this table that categorizes all of the available diabetes medicines in a table format. The classes can be itemized in this way. For instance, the glycoprotein receptor 1 agonists or the SGLT2 inhibitors, etc. We're going to talk more about these different classes and categories and examples of medications. But what a table like this will remind us about is that some medicines differ from others in their effects on cardiovascular outcomes, in their effects on common side effects like lower blood sugar or hypoglycemia. Some medicines may affect our body weights differently. Some will help us reduce body weight. On the other hand, some medicines will cause us to gain more weight, and we may get into this challenging kind of spiral of our body weight and diabetes. All the medicines will lower the hemoglobin A1C or improve blood sugar control, and some will have a modest effect, some will have a medium effect, and some will have a very large effect on blood sugar control. And we can choose medicines accordingly across all of these domains. And then each category of medicine might have its own particular attributes, either in a positive way that they may be helpful for particular populations, or each category of medicines might have particular considerations or side effects or warnings associated with them. And then finally, in the right-hand category here, we'll see that these medicines may differ by their cost. And so if we're thinking across populations or formulary reimbursement from government or private plans, that some may favor lower cost medications that might be older, such as down here, while restricting newer categories of medicines that might be quite costly, such as shown up here. So lots of considerations into one medicine versus another. Let's dive into this in a little bit more detail as we go through some of these categories. So summarizing some of the considerations around medication options, that's what's shown on this slide. We'll look for medicines that have a particular effect on blood sugar, whether they might offer some additional protection to the heart or to other vital organs in the body, such as our kidneys. We'll think about side effects, such as low blood sugar and weight gain. We'll also think about the route of therapies. So many medicines might be available as pills, and other ones are available as injections. And some people take a combination of both of these things. Some people prefer injections over pills, and some are vice versa. So there's lots of very good considerations on how we might arrive at one or the other. The other kind of route to think about, or the algorithm that we go through as healthcare practitioners and persons with lived experience, is thinking about the setting that we're in choosing therapies. An algorithm for management like this reminds us that if we think of people who are newly diagnosed or recently diagnosed with diabetes, then we will start with the healthy behavioral therapies and continue those throughout the interventions of management of diabetes. But then we may also consider how far away are we from targets to think about which medicines we might use. You will see that in most scenarios that we'll use an initial medication called Metformin. We'll talk about that in just a minute or so. And then depending if we're very far away from target, we'll add in either one or other therapies pretty rapidly. And if our sugars are very high and our bodies are very stressed, we may start with insulin right from the get-go to get things under control. Fairly quickly, we'll also ask the question of whether or not you have heart disease. And if you do have heart disease, then we'll be gravitating towards very specific medicines that have demonstrated beneficial effects for people living with heart conditions. Okay, so I think we've painted the picture that there's one, lots of options, and then secondly, lots of kind of customization that can happen along the way to match a particular scenario for the person living with diabetes. And let me just move on to here. So the first line medication for most people living with type 2 diabetes is this medicine called Metformin. One of its brand names is called glucophage. This is generally the first choice for people living with type 2 diabetes because it is quite safe, it is rather inexpensive, it might have some beneficial effects for people with the heart. And the way that it works, living with the heart, we're all living with the heart, living with a heart condition. The way that the metformin works is by making our bodies respond better to the insulin that we have. And it may also lower some of the sugar production that's coming out of our liver. So these are really positive effects on the body's kind of metabolism. Early on, nausea and diarrhea may be fairly common. The good news is that these tend to go away as we get used to the medicine. So sometimes when we prescribe this, we may start with a lower dose and then build this up gradually over a few weeks so that our bodies can get used to this medicine. It tends to have a very low risk of causing excessively low blood sugars, and it does not cause weight gain. So for all of these reasons, for most people with type 2 diabetes, this will be the first step, the foundational step. For some people who have somewhat higher blood sugars, we need to think about something else that we can add on top of the metformin. And we've got a few different options here as the previous tables and algorithms kind of told us. So one group of medicines are called insulin secretagogues. Secretagogue means secretion of insulin. That is, these medicines will give a kick at the pancreas. Pancreas is the organ that's in the middle of our body that's responsible for producing insulin. And these medicines help us push out a little bit more insulin to help us deal with elevated blood sugars. And a common example of this kind of medicine is called glyburide, or another one's called gliclazide. Because they are pushing more insulin in, around the body, the effect might actually happen, a side effect that might actually happen is an excessive lowering of blood sugar called hypoglycemia. And because if we have more insulin floating around, that tends to tell the body to actually create some more tissue and fat tissues and things like this. So we might actually experience some weight gain as a side effect of this. They are older therapies, they're quite inexpensive, so they're popular in that way. But for many people, we would rather try to avoid these side effects of low blood sugar and weight gain. So we're tending to move away from these insulin secretagogues for many people. Instead, we may be reaching for other newer kinds of blood sugar lowering therapies, such as these ones. So in the last decade or so, we've had the introduction of this class of medication called dipeptidyl peptidase inhibitors, or DPP4 inhibitors. Examples include these ones that are listed in the lower left-hand part of this slide. And you'll see that they all end in gliptin, and that's how we'll recognize them: allogliptin, linagliptin, sitagliptin, saxagliptin. They work to lower blood glucose by increasing insulin levels, particularly after meals, and lowering glucagon levels, which is another hormone that comes out of the pancreas that tends to raise blood glucose. So trying to rebalance our hormonal status that governs our blood sugar control. They tend not to cause weight gain, and they're associated with the lower risk of hypoglycemia. So they're more favorable or attractive compared to our insulin secretagogues, but they tend not to have as powerful effect on blood sugar. So they're kind of one of our medium category of therapies. So sometimes they can work very nicely with the metformin if our sugar levels are not too high, but they probably won't get us to a target level if our sugar levels are floating up very high. Instead, we might use some of these other kinds of newer categories. One grouping are called sodium glucose loop transporter inhibitors, or SGLT2 inhibitors. Examples are shown in the lower left-hand box again: canagliflozin, dapagliflozin, empagliflozin. So you see that they all have this suffix in their name here, gliflozin. They have an interesting mechanism of action, and we're going to talk a little bit more about that, by encouraging elimination of sugar into the urine. And when sugar gets into the urine, that can be effective for lowering the overall body sugar content. But one of the side effects that may happen if there's a lot of sugar that's coming out in the urine, and particularly traveling to our lower parts of the genital urinary tract, is that they may encourage yeast growth and bacterial urine infections and cause us to urinate a whole lot more. Some of this can be helpful, but some of this can be a nuisance sort of thing. Nobody wants to develop yeast infections. They're manageable with medications that can deal with yeast, but they may occur. They are associated with actually some loss of weight, so that can be quite positive. They are associated with a very low risk of hypoglycemia, so they can be quite positive in this way. And in stylized form, this is what's going on with this category of drugs called SGLT2 inhibitors, in that, you know, sugar is floating around in our body. It comes in through diet. It also comes from different kind of stimuli to our bodies, liver and muscle and other organs. Normally, the sugar that is floating around is handled by the kidney. It is usually filtered by the kidney, but then reabsorbed later around these little tubules in the kidneys at the level of something called the sodium glucose loop transporter. So the transporters encourage us to refilter and reabsorb the sugar so that we don't lose this. But if we actually block the transporter with one of these medications, then more of the sugar will appear in our urine. So that's how they work, in a very interesting kind of mechanism. When we lose sugar, we'll also lose salt, and we'll also lose water into the urine. And that's how some of the other effects on the body can actually happen. Lower body sugar improves glucose control. Lower fluid and lower salt in our body can improve blood pressure as well. So that might be very positive for our overall cardiovascular system. And we'll talk more about that in about 5 minutes. One other newer category of medicines are these glucagon-like peptide receptor agonists. Medicines like dulaglutide, exenatide, liraglutide, semaglutide. You'll see that they all end in tide. These the first versions of these medications were injectable, and now semaglutide is available both as an injectable and as an oral medication. They act to kind of mitigate or blunt the typical rise in blood sugar that happens after eating. They do so by helping boost the insulin levels after meals and lowering glucagon levels. So again, kind of rebalancing some of our hormonal responses to sugar. They also slow digestion and reduce appetite. Some people will actually experience nausea. The result of all of this stuff is that we have a better balancing of our sugar profile, and encouraging some people to actually lose weight along the way. So very nice kind of rebalancing of profile. And they are associated with a very low risk of hypoglycemia. So we don't go too high and we don't go too low, but we're better balanced overall in response to these kinds of therapies. One other injection that, of course, we've known about now for 100 years. This is the year that we're celebrating Insulin 100, celebrating the discoveries of Sir Frederick Banting and Charles Best, who discovered insulin in Toronto at the University of Toronto 100 years ago. And insulins are kind of replacing insulin that is normally made inside of our bodies. For people with type 1 diabetes, it was previously called juvenile type of diabetes or autoimmune kinds of diabetes. Then insulin is a mandatory therapy to replace the insulin that's missing in our system. And that's the only way to handle sugar and restore metabolism in a normal way. Some people with type 2 diabetes or adult onset diabetes may need insulin therapy as well, because the sugar levels are just so high, or our pancreas isn't producing enough insulin, or our bodies just aren't responding to the insulin that we have. So that some people will require the addition of insulin to get the sugars under control. And depending on individual needs, the healthcare provider may provide a mixture of insulin types to help sugar control throughout the day and night. And often people with type 2 diabetes will start insulin use with one single injection of a long-acting insulin at nighttime, and if necessary, add in more shorter acting insulins through the day. We can talk more about that through this table and then a couple of pictures coming up. But basically, this table is showing us that there's a bunch of different kinds of insulins that are available today. We kind of categorize them broadly as either ones that act in a fairly short fashion over 1 to 2 hours, or in a long fashion over several hours, up to 24 hours. And then there are some insulins that are a mixture of the two. They have a bunch of different names and different combinations and different companies that make them. And this is why you and your healthcare provider may choose one or the other that will best suit you. The idea of insulin therapy is that we try to mimic what happens in the normal or in the human body under normal circumstances. So if we think about insulin levels over here, and then meals that will be coming into the body at different times, then you'll see that with each meal, there is a spike up in insulin production through the body's response through the gut and through the pancreas with hormonal signaling. And there's also some baseline level of insulin in our body at all times, because there is this kind of basal level of metabolism that we're always producing a little bit of sugar and burning a little bit of sugar, and that's what keeps our body systems going. So if we introduce different kinds of insulin in the body, then this is what it might look like for a human kind of basal insulin, such as Humulin N. We can give an injection in the morning, it goes up slowly, and then comes down through the course of the day. But if we really want to deal with each of our meals, then we might give an additional kind of insulin that would go up and down like this. And this is what a human bolus kind of insulin might look like, or an analog kind of insulin might look like. So the combination of basal and bolus is what's going to get us to mimicking usual kinds of sugar, of insulin control through the course of the day. And then some people are offered mixes of insulin that might look like this, where there is a pre-mix of short and longer acting insulins to get us through the course of the day and through the evening. Or if we've got other kinds of newer formulations, they may look more like this. And you can see that they may give really good coverage for certain meals, but other meals may not be well covered. So the really modern approach is to give 4 or more different kinds of insulin injections through the course of the day to deal with the short term, to deal with the long term, as well as individual short term. So there's a real art and a science to giving insulin therapies through the course of the day. All right, so one more consideration that's quite exciting in our context of working together in the setting of heart disease management and diabetes management, which often go together, are more recent studies and advancements that speak to us that diabetes medicines may actually have an impact on the heart as well, over and above sugar control. And there's a series of studies that are conducted in a fairly similar way with a few different types of medicines that I'll show you in turn. So we're going to look at a couple of slides that look exactly the same, where we'll introduce a medicine like empagliflozin. The gliflozin, you'll recall, is an example of the SGLT2 class. Those are the medicines that block sugar filtering in the kidney so that we on net push sugar out in the urine. The effect of that is better blood sugar control, but it also pushes out salt and water and may improve blood pressure control, so that folks had this thought that maybe this category of drugs might be helpful for the heart as well. And indeed, interestingly, when this molecule was studied in this particular clinical trial, many people, in this case, 4,600 people, were randomly allocated to receive empagliflozin over about a 4-year period of time. And a couple thousand were instead allocated to receiving placebo. And what the study did was look at the experiences of people over the 4 years, and in particular looked at people to see if they would experience a cardiovascular event, such as a heart attack or a stroke, or actually died from one of these cardiovascular events. And the interesting thing that was found for people that were placed onto the active medication was there was a reduction by about 14% in the occurrence of these bad vascular events. So people that received this diabetes medicine for people living with diabetes, their sugar control was somewhat better, and their risk of developing a heart problem or a stroke was also better as well. So there was a declaration that these sorts of medicines were good for diabetes and also good for the heart. Similarly, the sister kind of medication in the class, canagliflozin, was shown to reduce blood sugar and was also shown to reduce cardiovascular events by remarkably the same amount, 14%, over a course of, in this case, 6 years. The other category of medicines called the GLP-1 receptor agonists, liraglutide. These are the injections that similarly balance out what's going on with the pancreas and metabolism. So insulin a little bit more effective, glucagon, not quite so powerful, oral kind of appetite reduced, better balancing, some weight reduction going on with these medicines. So when they are given to people at risk for heart disease, interestingly, over 4.5 years, thousands of people on liraglutide versus thousands of people on placebo, there was a 13% reduction in bad vascular events going on, very consistent with the story for the SGLT2 inhibitors. And then even further, one of the members of that SGLT2 class, the medicines that cause reduction in sugar, dump out more sugar in the urine, dump out sugar, dump out water, reduce blood pressure. Well, this category of medicines was also looked at in people who are living with heart failure. And some of you know that heart failure is one of these kind of challenging clinical heart problems where the heart may be impaired in its ability to pump. There's a tendency to hold on to salt and water and tip one over into heart failure symptoms. Well, interestingly, folks thought that, well, if we have this diabetes medicine that can help one control body fluid and help dump out sugar, salt, and water, then that might actually be helpful for people with heart failure as well. And indeed, that was what was seen for people, hundreds of people who were living with heart failure who received a placebo versus the solid red line, hundreds of people who had heart failure who received the active medicine. Well, there was a reduction, a dramatic reduction in the occurrence of future heart failure hospitalization or cardiovascular death over about a 4-year period of time. And the reduction in risk of these bad things happening was actually fairly large, of 38%. So the diabetes medications were shown to improve heart outcomes as well, and that was quite exciting. And that's led to kind of guidance in the clinical practice algorithms that if you're living with heart disease, then certain categories of medicines might in particular be helpful for you to manage the diabetes and the heart disease together. Okay, if you have found this information interesting and you want to learn more, then look at that chapter in the Diabetes College resource guide. Look at the Diabetes Canada website, and you'll find information not only for the healthcare providers, but also for persons with lived experience. And as we said, we'd invite you to visit us at the Cardiac College website as well, and the Diabetes College website to find the diabetes guide. Now is the time for your questions, in particular, if you have any. I see that thus far, there haven't been any queries put into the Q&A chat box. I'll leave that open for a minute and see if there's anything that you do want to pose. In the meanwhile, I'll just move to the last parts of this presentation. And this is to remind us that the Healthy University, Cardiac College, Diabetes College are now on social media, and we'd encourage you to link in and follow us at healthyu_TRI. And then the other very interesting innovation right now is that we have recently launched a stream of the program within our center devoted to people living with diabetes. So like there is a virtual cardiac rehab program, there is now a virtual diabetes program. And if you want to check out some of those materials, once again, you can visit the Healthy University site, click on the Diabetes College section, and you'll find a link to the virtual diabetes program. Okay, I don't see that any questions have come through. If something does come up in the future and you want to pose them to me or another team member, please just link in with your rehab case manager, cardiac rehab supervisor, and she or he can feed the questions to the appropriate individual. So thanks very much for your interest and participation in today's session. We will be returning with more of our live sessions in about a month. And stay tuned and link in to the Cardiac College online session to view the live events calendar and link into those live sessions. We'll also ensure that your case manager will share information about upcoming live sessions with you through the group meetings. Okay, take care. Thanks for participating, and I wish you a very healthy day, and keep up with your great activities and staying healthy. Take care.